Thank you so much for joining me today. My name is Lauren Oshman. I am a professor at the University of Michigan Medical School and a diplomat of the American Board of Obesity Medicine. I'm also board certified in family medicine, and I'm the program director for MCT2D, the Michigan Collaborative for Type 2 Diabetes. This recording is a 2026 update on weight management medications. We thought this would be a really helpful update to give with some of the different changes in medication insurance coverage and new medications in 2026. Our agenda today is going to be first to look at different changes for Michigan Medicaid insurance for weight management medications in 2026. And then we're going to review in depth some first generation weight management medications, phentermine topiramate, naltrexone bupropion, and phentermine. And then we'll highlight some new weight management medications that will be new to you and your patients in 2026. So some important framing, and one of the reasons that we're sharing this webinar is a recent change to the Michigan Medicaid formulary. In January 2026, Michigan's bipartisan budget restricted GLP-1 based therapies for the indication of weight management. And it's important to appreciate that Michigan Medicaid will continue to cover these medications for type 2 diabetes. There's really no change in treatment or coverage for that indication. And so, I and a group of obesity medicine physicians advocated for Medicaid to start covering these medications in 2021 or to cover obesity treatment in general with pharmacotherapy. And, as you might expect, utilization increased from an initial 20,000 patients to 90,000 patients in 2024. And spending on these medications increased. What I want to clarify is what this means. If Michigan Medicaid paid the list price for Wegovy in 2024, $1,200 a month for 12 months for 90,000 individuals, that would look like $1.3 billion on paper. But Medicaid's post-rebate spending is much lower, less than $100 million, because manufacturers provide discounts and rebates that reduced the net cost to the insurer. The total Michigan Medicaid budget is $25 billion, so this does represent just a fraction of total spending. But in order to reduce total spending in the state budget, the legislature has directed MDHHS to reduce total spending to only individuals affected by severe obesity. You can bookmark this website at Prime Therapeutics. This is where changes will occur throughout the year to updates that you may want to be aware of. I'm going to walk you through this announcement just so that it's clear what's changed. So starting in January 2026, selected GLP-1 and GIP medications, when prescribed only for weight loss or obesity, and that includes liraglutide, Saxenda, semaglutide, Wegovy, and tirzepatide, Zepbound, have these new coverage limitations. And these are, number one, for individuals who are classified as having severe obesity. And here this means a BMI of 40 or more. We do not use the term morbidly obese. If the Michigan legislature has asked me, I would have asked them not to use that term. And with step therapy, those requirements, again, require us as clinicians to document the failure of other clinically appropriate weight loss interventions. And of note, people who were approved prior to January 2026 will have their prescription honored for the remaining authorization period, which is typically up to 6 months. But new prescriptions will not be approved unless they meet these new guidelines. So what you're going to see is some patients already, you've been transitioning off, and other individuals will lose their coverage in July 2026, for example. So moving along, this is a screenshot of the current preferred drug list. And again, please bookmark this website, mi.primetherapeutics.com/provider. You can always access the newest version of this document, and this presentation will be out of date as soon as it's updated. But you can see here preferred agents and non-preferred agents. Phentermine products, including phentermine topiramate, as well as orlistat and other stimulant agents that we less commonly use, are preferred. What you'll also appreciate is that there is a medication, naltrexone bupropion, or brand name Contrave, that is not on formulary for Michigan Medicaid. And then below that, you're going to see three additional indications that are cardiovascular risk reduction, and MASH, and obstructive sleep apnea. And you're going to see there's a preferred agent for sleep apnea, that's Zepbound, brand name tirzepatide, and there's a non-preferred agent for cardiovascular risk reduction and metabolic dysfunction associated steatohepatitis, and that's Wegovy branded semaglutide. So for each of these medications, Medicaid in Michigan provides really ample information for you as the clinician about what criteria are required to approve a medication. And so here you'll see the criteria to approve, and I'll walk you through each of those additional indications for cardiovascular risk reduction. And that is an attestation that you'll not use Wegovy with other GLP-based or non-GLP-based weight management therapies. You will not prescribe it along with DPP-4 inhibitors, that the patient's BMI would have started at 27 or more. And so if someone has been initiated on another medication and you're switching them or submitting this authorization mid-treatment, always just make sure that your progress notes indicate their starting BMI, that peak BMI before they started treatment. And you're going to submit documentation regarding their cardiovascular indication, which would include evidence of peripheral arterial disease, prior myocardial infarction, or a prior stroke. And then there are some additional pieces of information they ask for. So then we're going to think about when we ask for renewal, there is going to be an additional attestation that's required, and patients will be required to show a maintained weight loss of 5% from their baseline weight at the initiation of therapy. This is the first slide with data I'll show you in this presentation. This study was from 2025, and this was a secondary analysis of patients in the SELECT trial, which was the cardiovascular outcomes trial for semaglutide for cardiovascular risk reduction. So what I think is really interesting here, and you'll see patients prescribed semaglutide on the left and placebo on the right, is that the risk reduction in events, in major adverse cardiovascular events, didn't vary based on whether patients lost more than 5% of their weight, lost less than 5% of their weight, or gained weight. There is something about potentially inflammation or the other benefits of this medication that aren't necessarily determined by weight loss. And so other than Medicaid changing their criteria, just for you to be aware that the medication is still effective, but Medicaid will require documentation of 5% weight loss at that 6-month mark. So then moving on to the second kind of special indication, and that's for metabolic dysfunction associated steatohepatitis, and that non-preferred agent is semaglutide or Wegovy. This all looks exactly the same as cardiovascular risk reduction, except that you're going to need to provide some attestation about the patient's diagnosis. And typically you'll be submitting their FibroScan test result, which is that non-invasive test that risk stratifies patients into F2, F3 fibrosis. That would be the group that Medicaid covers for this medication for that indication. Certainly a biopsy would be less likely to be performed, but could be submitted if available. And then similarly, when you go back to request renewal at 6 months, you will demonstrate in your documentation a weight loss of 5% or more from their initiation of therapy. So then the last special indication or non-weight management indication is for obstructive sleep apnea. This is a preferred agent, at least at this time, tirzepatide or Zepbound. Again, all of the information is the same except focusing on that attestation for the patient's diagnosis of sleep apnea. And so you're going to submit typically a sleep study, and I'll tell you a little bit more about that. When you go to renew, again, at that 6-month mark, you're going to demonstrate that the patient has had weight loss of 5% from their baseline at the initiation of therapy. And so Medicaid doesn't provide a lot of transparency about any other requirements, such as a need for patients to be treated with CPAP prior to prescribing for sleep apnea. And they don't specify exactly what test criteria they use. I will just tell you in general, for most insurance companies, they will accept either a polysomnogram or a home sleep apnea test, PSG or HSAT. Polysomnogram is going to give you AHI, and a home sleep apnea test is going to give you REI. AHI is apnea hypopnea index. And for moderate to severe, those numbers look the same. Moderate is 15 to 29 events per hour, and severe is 30 or more. So just to give you context, I recently had a patient who had a abnormal hospital-based PSG test. They had mild sleep apnea with an events per hour number of 10. They would not be eligible for tirzepatide or Zepbound for treatment because they do not have moderate sleep apnea. And then I've just indicated here for you on the right the template that I use in letters to insurance companies, just demonstrating what was the patient's criteria and then talking about some of the study evidence for the drug's effectiveness. So hopefully that information helps give you a groundwork for the three indications that are not weight management based: cardiovascular risk, sleep apnea, and MASH. So now we're going to move on and talk a little bit more about how Michigan Medicaid's change is going to affect our patients for whom we are prescribing these medications just for obesity or overweight or weight management. So we'll start with a case. This is JR. JR is 37 years old. JR's weight is starting at 265 pounds or a BMI of 38. So he does not have severe obesity per those classifications. Hypertension, hyperlipidemia, and prediabetes. He has Michigan Medicaid insurance. He's just completed a calorie-restricted Mediterranean-style eating plan and increasing his exercise through the diabetes prevention program. He really appreciated the program. He lost 5% of his body weight, and his weight is now 250 pounds with a BMI of 35.9. And so to yourself, think, which medication do you think would be appropriate for this patient? Phentermine, Orlistat, the combination Phentermine topiramate, the combination Naltrexone bupropion, liraglutide, which is brand name Saxenda, semaglutide, which is brand name Wegovy. I should say liraglutide does now have generic availability. Semaglutide PO for obesity, which is branded Wegovy pill, tirzepatide, which is branded Zepbound, or orforglipron, which is branded Foundayo. So the answer is really any of these options would be appropriate, would be within what would be appropriate. And I'll take you a little bit through the history of weight management medications and where we are in 2026. Phentermine and other sympathomimetic amines were approved initially in 1959, Orlistat in 1999, Phentermine topiramate in 2012 as brand name Qsymia. In 2014, both Contrave, which is bupropion naltrexone combination, and liraglutide for obesity Saxenda were approved. 2021, again, we're talking now about newer generation GLP-based therapies. Semaglutide Wegovy was approved in 2023, tirzepatide Zepbound. And just in the last few months of 2026, Wegovy at a higher dose, which is now branded Wegovy pill, and just in the last few days, orforglipron or Foundayo were approved. So how do you decide which medication might be appropriate for a patient? You might think about their efficacy. And what I've done in this chart is subtract placebo. So these numbers look much better when you think about not subtracting out what a placebo would achieve. And what we see for Orlistat is that effectiveness is about 6%, placebo is about 1 to 2%. And so the placebo subtracted effectiveness is about a 3.8% weight loss at 1 year. Naltrexone bupropion, again, can be effective for some patients, but on average is about 4.8%. Liraglutide, about 5.4%. And then there's a bunch of medications that achieve about a 10% weight loss, and that includes Phentermine topiramate, orforglipron, semaglutide, both as a pill and subcutaneous injection. And then we see tirzepatide having a larger placebo-subtracted weight loss than those medications. And these numbers are all maximum dose in clinical trials amongst patients without type 2 diabetes. But patients aren't averages, and so oftentimes when we're determining medication appropriateness for patients, we're thinking about what is their weight loss goal for their metabolic indication. That might be very different for resolving sleep apnea than it would be potentially for someone with hypertension that might resolve with a smaller amount of weight loss or improve. And so here you can see our first generation drugs, both phentermine and topiramate and naltrexone bupropion, and you can see the percent weight loss in different colors. And what we can appreciate is at that 15% weight loss, we do see a portion of patients achieving 15% weight loss with both of those drugs, slightly more with phentermine topiramate. And what we can see with our newer generation GLP-based drugs is that that percentage is just higher. It's just more likely that someone might achieve 15% weight loss. And then we start to see weight loss subgroups that we don't see with some of our newer medications. And that for semaglutide is reporting 20% and higher, which is still a minority of patients, and tirzepatide presenting 25% weight loss or higher. And those truly are numbers that previously were only achievable with bariatric surgery. But as a board certified obesity medicine physician, I feel very comfortable starting with a first generation medicine and then pivoting if that patient does not respond. But knowing that a percent of patients will achieve that appropriate weight loss for their weight management goals with one of those first generation medications. The next information I want to show you is from a new guideline. This is the AACE guideline from 2025 that really is an excellent resource for weight management. Dr. Karl Nadolski is one of our MCT2D participating endocrinologists and a real leader in this area, and we're lucky to get to work with him. And this figure lays out some of that clinical trial data for which co-occurring condition might guide your choice of weight management medication. And here they're using the term ABCD or adiposity-based chronic disease. And you can appreciate that there is data for different medications, for different indications, but some that you might not always think of. So for example, for diabetes prevention, phentermine topiramate does have trial data supporting a benefit for diabetes prevention. This graphic presents the same information in a slightly different way, and it also presents information about contraindications, medications that you might not want to use, and medications where you might want to do some more monitoring. And you can see the medication across the top and the indication along the side. And so what we might think about for our patient, JR, and his concerns for type 2 diabetes and hypertension, that there would be potential benefit from orlistat, from phentermine topiramate, as long as we're watching blood pressure and heart rate, and from either liraglutide, semaglutide, or tirzepatide. Any of those medications would be appropriate to try. Then if we take a look at this graphic, and again, I think this is a great resource for you to think about as a point of care resource, you're going to see all of the basic information about how the medication works, starting dose and escalation, and some of those really important precautions and absolute contraindications. And so these are resources that I'll put the reference in at the end, and you can download for your use later on. And so JR, again, does not have severe obesity. BMI is not 40. And so the preferred options with Michigan Medicaid are going to be either one of those phentermine products or phentermine topiramate or orlistat. So we decided together to try phentermine topiramate. The next several slides are going to be a deep dive into this medication. So if you feel comfortable with it, you're welcome to fast forward to the end. But I think this is really important information for people maybe who are not as comfortable prescribing the medication. And so I hope this is helpful for you. This medication's brand name was Qsymia, but in 2025, the first generic option for this medication was approved. So throughout these slides, I'll be calling it phentermine topiramate, but may use the brand name Qsymia for shorthand. From a phenotype perspective, I think about this for patients who might be a mindless eater, someone who's grazing throughout the day, someone who feels like their fullness or satiety signals just aren't showing up. And because topiramate is effective for migraine prevention, I will also use it for someone where there is that dual benefit. The timing is easy. This medication is 1 pill a day, and about 50% of people who use it lose 10% of their body weight. I do want you to keep in mind that it is a Schedule 4 controlled substance, and it does need to have dose adjustment both for kidney and liver disease. I won't go into a deep dive into the neurophysiology of how this medication works, but most important to appreciate is that the way that phentermine and topiramate affect weight set point occurs in the hypothalamus, but they affect changes both in the hunger pathway as well as the satiety or fullness pathway. Topiramate working through that GABAergic pathway, and phentermine acting on sympathomimetic or norepinephrine pathways. So there's also pathways in the prefrontal cortex with dopamine neurons. We don't really know to what extent those are important in weight control. So here's dosing information. These pills have different colors, which is helpful for your patients. The main pitfalls I've seen with prescribing of these medications by primary care clinicians is that they may forget to dose escalate and forget that the 3.75 and 11.25 milligram medications are really not meant for maintenance in the clinical studies. So you'll start with 3.75 milligrams of phentermine, 23 milligrams of topiramate, once a day in the morning for 14 days, and then you'll escalate to 7.5. That typically we will hold for 3 months. And then at the end of that 3 month period, if someone has lost less than 3% of their weight, we will then escalate through the 11.25 milligram dose for 14 days and then to the 15 milligram dose. And if that's tolerated, we'll keep it there for another 12 weeks before making a decision. If someone has lost less than 5% of their weight, we'll discontinue, and otherwise we can continue if that patient tolerates that dose. When we're tapering, there's no need to taper the lower doses, but the 15 milligram dose, the prescribing information does recommend that you take one pill every other day for a week before stopping. So before starting this medication in a person of childbearing potential, you should be obtaining a negative pregnancy test and recommending effective contraception. And that is because of the risk of teratogenicity, which includes cleft lip and palate, as well as an association for small for gestational age. And because of this, there's a REMS program, a risk evaluation and mitigation strategy program. Doesn't require you to do anything, but the pharmacy is required to give information to the patient. So that's the major warning or precaution to be aware of with phentermine topiramate. Here are the 5 contraindications. Again, there's very few patients for whom I would not prescribe this medication. The first is glaucoma. That is an absolute contraindication in the package label. The second is hyperthyroidism because of that noradrenergic load. The third is if you have an allergy. The fourth is if you've used a monoamine oxidase inhibitor in the last 14 days, and the fifth is pregnancy. And I would say the only ones I see really frequently come up in my practice, obviously pregnancy, but also glaucoma. So that's something I'm careful to ask my patients about. Looking at this screenshot from a resource that provides information about safety in pregnancy and lactation, you can see that the lactation information gives you a yellow check mark. Again, breastfeeding could be considered with close monitoring, and question marks during pregnancy, again, because we know that that medication can cause birth defects. So this is just a screenshot from the REMS program and what we want to recommend to people of childbearing age, especially because weight loss can increase fertility, is a highly effective method to use alone, which might be an intrauterine device or the other options you see here, or 2 acceptable methods that are effective used together, or option 3, which includes a barrier method and another barrier method. So here's warnings and precautions. Again, this is just information I've derived directly from the label to share with you. And I think the first issue to talk with patients about is suicidal thoughts. And I've definitely had some patients who had concerning suicidal thoughts, and we had to stop this medication either temporarily or long-term. Suicidal behavior and ideation is known to be associated with many different anti-epileptic drugs, can occur as soon as a week before starting treatment. And so I just talk to families and patients about this so that they know what to look out for. I would not prescribe this medication to someone with a history of suicide attempts or with active suicidal thoughts. For other individuals, I would just monitor them for worsening mood issues. Even though we recommend dosing in the morning, some people are going to have sleep issues with it. One of the more common reasons that people will not tolerate phentermine topiramate is because of the cognitive issues. People will often say, I had brain fog, my memory, my concentration wasn't as good. And then thinking about not co-using this medication with alcohol, not having people operate heavy machinery until they're sure how it's going to affect them. There are rare reports of seizures withdrawing this medicine, even in people who don't have a seizure disorder, and that is with the 15 milligram dose. And so that leads to the prior recommendation to taper that 15 slash 9.2 milligram dose. Vision issues, again, I do mention to my patients out loud and include in information for them. If you're having blurry vision or acute eye pain, stop the medication and we're going to have you see an eye doctor immediately. So those are signs of secondary angle closure glaucoma, which can occur even in people without a prior diagnosis. The next category of things to think about are the metabolic effects, and this is through the carbonic anhydrase inhibition mechanism of action of topiramate. So this can cause renal tubular acidosis and a non-anion gap metabolic acidosis. So we want to avoid other carbonic anhydrase inhibitors. We'll see a drop in bicarb levels, and that usually occurs in the first 4 weeks of treatment. We can see hypokalemia, and usually, again, that drop happens in the first 8 weeks of treatment, and that can be worse in patients who are already taking additional diuretics that are not potassium sparing. Topiramate can increase your creatinine and decrease your GFR. This again will peak around that 1 to 2 month range, and so typically with any patients, I am going to be checking a basic metabolic panel before starting, and then again at the 1 and or 1 to 2 month range. And if I'm seeing any changes, I'll continue monitoring. Or if people are starting a new medication or there's a new issue or condition that might exacerbate that metabolic acidosis. Kidney stones are complicated. The presence of kidney stones is not an absolute contraindication to use this medication. The carbonic anhydrase inhibition reduces urinary citrate. It increases urinary pH, and that favors the deposition or precipitation of calcium phosphate. The ketogenic diet actually can make that worse, and so we want to maybe potentially caution people with a pre-existing diagnosis of kidney stones or with a risk for kidney stones from combining these two interventions together. So to put this in context, in the clinical trial of Qsymia, the risk of kidney stones was 0.3% for placebo and 1.2% in the 15 milligram highest dose for Qsymia. So it's still relatively rare, but we do want to do no harm. Thinking about how to help patients, we want to make sure that people drink enough water, and then I'll give you some other suggestions in a second. In the right-hand column, these are less common, rare side effects, but again, just things to keep in mind, especially that allergy to yellow dye. So this is just a list of the most common adverse reactions and drug interactions from the prescribing information for this medication. As I said before, brain fog or dizziness, insomnia, kind of the mental aspects of this medication are the most common ones that my patients say, this is not for me, I'm having a side effect, we need to try something else. And then the second group, dry mouth or funny taste in the mouth, dysgeusia, can be experienced with this medication as well as constipation. The second class of adverse reactions to be aware of is cardiovascular, and so the label does include a concern about increases in the heart rate and recommends monitoring of heart rate and blood pressure. It used to be that the label stated that you should not use this medication with recent or unstable cardiac or cerebrovascular disease. Now, that was removed in 2025, but if you have been prescribing this medication a long time, you'll wonder where that information went. It was removed from the label. What we do know is that the heart rate increase in clinical studies is 1 to 2 beats a minute, but can occasionally be more than 10 beats a minute. So really just do let patients know and keep your eyes out for that. We also don't really have any cardiovascular outcomes trial on phentermine topiramate. So we can't really extrapolate this data to say that it's truly safe in people with pre-existing cardiovascular disease. Here's information about drug interactions. Certainly don't co-use with alcohol until you know how the medication is going to affect you. Thinking about the information I already gave you about contraceptives and non-potassium sparing diuretics. And then not prescribing alongside carbonic anhydrase inhibitors and being very, very cautious with other anti-epileptic drugs. You may wonder about a drug interaction with topiramate and oral contraceptives. The dose of topiramate is so low that it is not thought to make oral contraceptives less effective, but it may increase breakthrough bleeding. So if a patient complains of bleeding, I might increase the estrogen dose, use a higher estrogen dose in that oral contraceptive pill. So just something to watch out for and make sure your patients are thinking of it and you're thinking of it. All right, so I am going to skip over this slide that we already went through and then move on to talk about troubleshooting side effects. So these are just like quick tips from other experts that I've seen presentations given on this topic for the paresthesias and the brain fog and to reduce kidney stone risk. Increase your fluid intake and acidify your urine. People will do that with water with a quarter cup of lemon or lime juice or 1 packet of true lemon and lime in water daily. Some people will just give patients vitamin C, 500 milligrams daily, which is an easy intervention. Some people will prescribe Urocit K. And if you have a patient with other concerns or co-occurring chronic kidney disease, think about co-managing them with nephrology or urology. The thing that I'll tell my patients about the funny taste in their mouth is oftentimes people who are addicted to Coca-Cola or other cola products will stop drinking them because it makes carbonated beverages taste bad. But people can also use lemon drops, but just an interesting side effect of this medication. All right, so that is your deep dive on phentermine topiramate. And so now we go back to Medicaid. Now, even for patients with a BMI under 40 and using those preferred medications, Medicaid may ask you for an attestation. So I will typically include this information in my progress note. This is an AI version of me and an AI version of Lakia, who is really my prior authorization team member at my office. And I will take this moment just to appreciate all of our team members because certainly working with insurance to submit prior authorizations is a team sport, and I could not do this without her. So things that we're going to attest, again, same kind of format as what I showed you prior. We're not using more than one weight loss medication in this drug class concurrently. I'm giving them the initial BMI. I'm ensuring that the patient doesn't have an eating disorder, that I've ruled out diabetes and other metabolic causes for obesity, no contraindications. I always prescribe a diet and exercise plan, but they do want to see that in writing. And then recommendation that patients consider diabetes prevention program. And of course, JR had already completed that. And then this form is what you would see on paper. Many of you might be using an online prior authorization program, but walks you through all of those pieces of information that will be asked for. So let's move on to another case. And this patient is AB. AB is a 25-year-old female with BMI of 35, initial weight of 200 pounds. They have irritable bowel syndrome, asthma, and depression in Michigan Medicaid insurance, and they have been adhering to a calorie-reduced eating plan and exercise and not experienced any weight loss. AB is sexually active with one male partner and prefers to use natural family planning to prevent pregnancy and really isn't interested in using a hormonal or highly effective contraceptive method at this time. So I'll just show you again, these are the preferred drugs for, again, those patients with BMI under 40 for whom Medicaid does not cover GLP-based therapies anymore. Those are limited to patients with a BMI over 40, and we could think about any of these options for this patient. I wouldn't necessarily prescribe orlistat for someone with irritable bowel syndrome. Many patients do not tolerate it because it does cause diarrhea. When you're submitting prior authorizations, I think you can just write your medical recommendations. I do not recommend orlistat for this patient because, and again, I have not seen any concerns with insurers, including Medicaid, appreciating your medical decision making there. Similarly, I prescribe a lot of phentermine, but I don't prescribe bensphetamine, diethylpropion, or phendimetrazine. And so I don't expect other primary care clinicians to prescribe those medications if you don't consistently use them. Frankly, they're less commonly available in pharmacies and somewhat less data and overall use. And so if you're trying a phentermine product like Adipex or Lomira, which is low dose phentermine, then in your prior authorization or attestation, I think just say like the reason that I'm not using these other medication is because the patient has already tried or already failed, has a side effect, contraindication to phentermine products in general. There would not be an expectation that you use like all five medications in that class. So I'm going to tell you a little bit about phentermine. Again, if you are already familiar with this medication, you can skip ahead. Medication is most commonly available in your pharmacies in the 37.5 milligram tablet formulation of Adipex P or the 8 milligram tablet of Lomira. Individualized dosing means that for me, I start low. I usually start with a half of a tablet or 15 milligram once daily, and then Lomira 8 milligrams can be used up to 3 times a day as an alternative if you like. Again, age for FDA approval is 16. This is a controlled substance. And you'll see some regulation and information on the prescribing information about short-term use, but I'll tell you why I think it is safe to use long-term. And then the pharmacokinetics of this medication peaking at about 6 hours. The reason that phentermine was approved short term is in 1959, there were not cardiovascular outcome studies. And so state guidelines are very variable on how they consider this medication and its appropriateness. So, for example, Ohio used to completely disallow long-term phentermine prescriptions by law. And in February 2023, due to a lot of advocacy, those rules changed. So, moral of the story, just be aware of the state law where you practice. In Michigan, there are no limitations. The only limitations are on providing refills because it is a controlled substance. So I want to just forecast that at the end of 2026, the LEAP trial, long-term effectiveness of phentermine, is going to close. And this trial is that longer-term look both at body weight, blood pressure, and also some really important secondary outcomes that will approximate cardiovascular risk. And I'm very excited to see the results of this study. So they are going to randomize individuals to placebo or phentermine, starting at 8 milligrams and then escalating to 24 milligrams once daily if tolerated. And those primary outcomes looking at body weight and change in blood pressure, and then also looking at heart rate variability, resting energy expenditure, and drug dependence. And they'll be tracking cardiovascular events, even though those are rare. And so here's some information again. Who should you not be prescribing phentermine? And I just want you to keep in mind, you just saw the information for phentermine topiramate. So why are they different? Really, most of that information is because the studies done are different than the studies that were done in 1959 with phentermine. So no prescribing for patients with a history of cardiovascular disease, and that includes coronary artery disease, arrhythmia, heart failure. No prescribing for patients with uncontrolled hypertension, and then you've already seen glaucoma and hyperthyroidism. They state agitated states here, a history of substance use disorder, recent monoamine oxidase inhibition use, pregnancy, nursing, and hypersensitivity. What are those warnings and precautions? We want to talk to patients about the risk for palpitations, the risk for an increased pulse, increased risk of tachycardia, elevated blood pressure. We want to talk to them about mood changes. People will comment on dizziness, headache, and dry mouth. I would say that most of my patients tolerate this medicine extremely well. We just really avoid use in the late evening due to insomnia. And then patients who have a lot of anxiety, irritability, sometimes do feel like their heart is beating fast and just don't tolerate this medication well. Again, screenshot on the right, looking at safety in lactation and breastfeeding. There's just not a whole lot of information on breastfeeding available. And so we have to extrapolate from other medications in the same class. And then you'll see information about primary pulmonary hypertension and cardiac valvular disease. Those were side effects of fen, which is phentermine, fenfluramine, and are not really known to be associated with the phentermine on the market now. but just wanted to show you since it's going to be in the prescribing information. So here's more information to help, I hope you feel more comfortable with longer term prescription of phentermine. And this study was a retrospective review of patients who were prescribed phentermine. You can see that there is a group that was just given the medication short term in dark red, who was given it on and off in orange, who was given it continuously for medium term in, I guess, chartreuse, and that was between 12 weeks and a year, and then medium term intermittent, and then you can see over on the far right, long-term continuous. So what do we see in terms of percent change from their baseline weight? We can see that phentermine is effective when given long-term. And so I'll show you one more slide. This is responders only. So prior slide was intention to treat, and this is per protocol. And then you're going to see that much more robust weight loss, that phentermine alone, again, in this retrospective cohort, the average weight loss was 10%. And you can see some people not as high responders and some people more. But again, going back to that message, I'm very comfortable starting patients on our first generation medications and then trying something else if it's not effective for them. All right, so this is a dot phrase that I'll have my medical assistant or LPN provide to patients when they're asking for refills. If they don't give me this information, I really do want to know about weight. They have to have a way to track their blood pressure at home and their heart rate. And then I make sure that I'm tracking behavior change and then giving them support as needed. We're going to start typically, and again, this is just my protocol, phentermine 1/2 tablet of the 37.5 milligram tablet every morning. With that robust lifestyle program, we're going to monitor and then we're going to note their baseline weight. And then this is adapted from different escalation protocols, but we want to assess every month. And typically, again, I tell patients, call me sooner if you have problems, but at that 1 month mark, how is your blood pressure and your heart rate? And if you're noticing any concerns concerning increase in heart rate or blood pressure or lack of tolerability, we'll stop. If it's tolerable, we'll continue. And then if we see no change in weight, we can consider a dose increase there. And then at that 3-month mark, I really want to assess their response and make a decision. Should we continue this medicine or is it not working for you? So after 12 weeks, we will say if you've not had at least 5% of your body weight loss, then I might consider it discontinuing. And then if you have more than 5% body weight loss, we may want to continue as long as that risk for cardiovascular risk is low. So wrapping that in a bow, that is how I would manage a patient with phentermine, initiating that medication for obesity medication treatment. So we will move on to case 3, and this is patient DT. They are a 58-year-old female with BMI of 39 or 240 pounds. They have depression, glaucoma, and kidney stones, and they have Michigan Medicaid insurance, and they have adhered to a calorie-reduced eating plan and exercise and not experienced weight loss. So when we think about which medications would be appropriate for this person with that history of glaucoma, that's kind of a absolute contraindication to the phentermine or the phentermine topiramate products. And so I'm thinking about naltrexone bupropion for this patient. And so bupropion naltrexone should be flipped, also brand name Contrave, and there is no generic at the time I am recording this webinar. Comes in an 8 milligram naltrexone, 90 milligram bupropion extended release tablet, and the dosing is a little bit more complex with 1 tablet every morning for a week and then titrating up to 2 tablets twice a day. And that max dose needs to be dose adjusted with CYP2B6 inhibitors or clopidogrel. That's really the only dose adjustment that you'll need to remember or refer to. How does this medication work in the brain? So bupropion has a mechanism of action increasing dopamine and norepinephrine in the prefrontal cortex and stimulating that satiety center, increasing the sense of satiation and fullness in the hypothalamus. Naltrexone is an opioid antagonist, and it blocks some of the appetite stimulating effects in the opioid pathway in that nucleus accumbens. So there are different pathways in the kind of reward center of the brain, as well as working on the satiety neurons in the hypothalamus. So important to note and explain to people dosing and making sure this is going to work for them. So you start with one pill with breakfast, and then the second week, one pill twice a day, third week adding one, and finally you will get to two pills in the morning and two pills at night. A little bit of a tricky issue is that we don't want to take this with high-fat meals because it will increase the systemic levels of bupropion and naltrexone. So a well-formulated high-protein diet that is calorie reduced would be fine, but I would have some caution with a very high-fat, ketogenic, or very low carbohydrate diet. So let's look at contraindications. Again, super safe for the vast majority of people. We're not going to prescribe for uncontrolled hypertension, for seizure disorders, eating disorders, chronic opioid use, or monoamine oxidase use within 14 days. The reason is that naltrexone blocks opioids. So if you were using chronic opioids, they will not work if you're taking naltrexone. That would be a bad combination. Looking at those warnings and precautions, and this is mostly from the bupropion portion of the medication, there are known with many, many antidepressants changes in suicidal thoughts and mood changes, and certainly bupropion can change the seizure threshold. So those are things we want to think about and communicate with our patients. Interestingly enough, in clinical studies, bupropion elevates blood pressure and heart rate more than phentermine, but I feel like not all clinicians remember that, and phentermine gets a bad rap. And all of the studies of this medication excluded people with a history of heart attack or stroke in the recent 6 months, or arrhythmias or heart failure. We just don't have data for this medication in that group of people. And so I would just really use the medication with precaution. The hepatotoxicity risk is at high doses of naltrexone. I also have board certification in addiction medicine, and so we're very careful about how we use naltrexone in patients with liver failure. But again, I would just say avoiding this in patients with severe liver disease. And then again, that risk of acute angle closure glaucoma, just warning people about looking at visual changes. With any medication that can cause weight loss, it can affect your blood sugar if you're taking other medications that can cause hypoglycemia, so keeping an eye on that. In terms of adverse effects, nausea, vomiting, constipation, diarrhea. Really, with all of our anti-obesity medications or weight management medications, those are adverse effects to be aware of. I think what bothers my patients some more is mood changes, dizziness, insomnia, and headache. So just kind of being aware of that. So drug interactions to keep in mind, CYP2D6 medications, and I just want to draw your attention again, limiting the dose of Contrave when you're going to be using that with clopidogrel or ticlopidine. Also noting that it can cause a drug test to be false positive for amphetamine on your enzyme immunoassay or office-based drug test. So that would be important to keep in the back of your mind. And then looking at safety in pregnancy and lactation, even though we wouldn't prescribe these medications to someone while they are pregnant, these medications have reasonable information that there's no harm noted. So not something that I worry about so much in terms of conceiving near the time of use of these medications. So I'm including some information here about off-label drug use. And so off-label use of naltrexone and bupropion, for example, for patients who have Medicaid insurance and the brand name is not covered, I will prescribe patients a combination of bupropion and naltrexone. And when I do that with the two generic medications, I'm starting one and then adding on the other. And typically I will start with bupropion and I will try that for a couple of weeks. And then I will add on naltrexone and dose adjust as tolerated. And some people tolerate this medication 25 milligrams twice a day. Other people need a lower dose of medication. It really allows me just to look at side effect profile. Naltrexone can cause nausea, and so as we're up titrating it, I just make sure that I'm aware of that. So just again, sharing information with you about phentermine and topiramate. If I'm going to prescribe these medications separately, maybe I'll start with phentermine and then I will add topiramate after a few weeks and then dose titrate as needed. And there's a couple of different ways that you can do this. Topiramate ER historically has been a more expensive drug, so oftentimes I will just use topiramate immediate release, but both of these regimens are used in obesity medicine settings. So let's go back to our patient. DT has been trying bupropion and naltrexone, which you prescribed as the generic options, tried for 6 months, didn't experience any weight loss. You then tried phentermine, but they experienced really problematic anxiety. I think in this case, I took away the glaucoma in between adjusting it. So for the purposes of this presentation, um, just again, we're giving you an example of someone who tried the approved options, and now you're thinking about a patient for whom you might want to prescribe a GLP-based medication with Michigan Medicaid, and she's gained weight. So now her BMI is 40, and she has severe obesity, and she might be someone who would be a candidate for a GLP-based medication under Michigan Medicaid. So I'm going to take you back to Medicaid and looking again at those non-preferred GLP-1 based therapies for patients where we're only prescribing it for obesity or weight loss. So the criteria to approve is either an allergy to all 5 types of preferred medications, and the list is here, or a contraindication, or a drug interaction, or a history of unacceptable side effects, or they've tried and failed all of them. And you'll see here in the fine print at least one orlistat and one phentermine product in addition to bensphetamine, diethylpropion, and dimetrazine. What I will tell you is that use your clinical judgment. If you have tried phentermine for a patient, if they have a contraindication, just again, share your clinical judgment in your progress notes or documentation. I am not recommending the prescription of these other sympathomimetic amines because of XYZ. Similarly, if you don't think it's appropriate for the patient to be prescribed orlistat because of existing GI conditions or other reasons, share that reasoning. All right, so Lakia and I go back to work. In my progress note, I attest that the patient has already tried the different medications that are required for step therapy, that they had an adverse effect of severe anxiety with phentermine, so I'm not willing to try other sympathomimetic amines and other contraindications. And so I submit all of that in order to have Medicaid consider this patient for preferred or non-preferred agent for GLP-based treatment for obesity. And again, all of that information looks really fairly similar to the information that you saw for all of those other indications. Okay, so our patient DT was able then to have semaglutide subcutaneous approved because of trialing all of the first line or preferred options first, tolerating treatment well. I see her back every month. Typically, I'll do portal messages and in-person visits if someone needs additional support and make sure someone is getting that robust lifestyle plan. Oftentimes, it's through the diabetes prevention program because it's available to people through health insurance and it works so well, but that could be through any other program in their community. And then I document that she's continuing to adhere to that calorie-reduced eating plan and exercising. She's lost 7% of her weight. Weight is now 232, and I submit that for her 6-month renewal of her medication. So when we think about, again, renewal information, insurance is just going to look for that individual having appropriate weight loss, and they're going to look at quantity limits, which would be, again, typically what we would recommend for this patient anyway. All right, so I hope at this point in the presentation, you feel comfortable with options that are first generation weight management medications and have a pretty good understanding of where to find information from Michigan Medicaid. You've already listened for 53 minutes, and so if you have no interest in new medications, you can stop now. But I do want to share some information with you about newer medication and new doses of medication that have just been approved in the last few weeks of 2026. So the first thing that I want to share with you is approval of 7.2 milligrams of semaglutide subcutaneous injection. This was approved March 19th, 2026, and I am recording this on Sunday, April 5th, 2026. So this medication, to my knowledge, isn't even available to order yet, but will be available soon. This is a clinical trial called the Step Up trial, and they randomized people to either a placebo, 2.4 milligrams of semaglutide, or 7.2 milligrams of semaglutide, all with intensive lifestyle support for 72 weeks. And the exclusion criteria are similar to what you're going to see in other semaglutide trials. So when you look at the average weight loss, you're going to see gray, which is placebo, blue, which is 2.4 milligrams, and purple, which is 7.2 milligrams. And you're going to see increased weight loss in that purple category. On the left, you see in trial, and that means intention to treat. Some of the people dropped out, and so those numbers are a little bit lower. Weight loss was 18.7% on average. On the right side, you're going to see on treatment. And that means per protocol, that only includes the people who are able to stick with it and take that maximum tolerated dose of medication. And those individuals had 20% weight loss. So we can appreciate why this trial was done. The manufacturers of semaglutide appreciating that tirzepatide had a increased effectiveness of weight loss at that 20% cutoff, and testing this higher dose for safety and efficacy to see if it would as well provide enhanced weight management benefits to patients. So this graph has a lot of information, but I think it's just important to keep in mind not everyone is a responder to these medications. So you're going to see purple, that 7.2 milligram dose, blue, the 2.4 milligram dose, and gray is the placebo. And you can appreciate that, really in, again, the per protocol, so this includes people who were dropouts or didn't tolerate, almost everyone, 90% or 9 out of 10 people lost 5% of their body weight. But what that means is that 1 out of 10 people did not respond to this medicine. And that's why we need to have so many different options to treat our patients. We can see, again, a majority of patients lost 10% of their body weight, about 6 out of 10, 15%. About half of patients in the trial lost 20% of their body weight with that purple 7.2 milligram dose. And then a third lost 25% of their body weight. So what we can appreciate here is that now that this dose is available, who are we going to use it for? So this is only for people who have established tolerability to 2.4 milligrams. So people must start at the lowest dose and titrate up to 2.4 milligrams subcutaneous and be on that for 4 weeks. And then you could consider titrating at that point. You could wait and see how someone responds and then only titrate to 7.2 milligrams if their weight loss slows or plateaus, really individualizing treatment. So what I think is important is side effects. So the first number is the 7.2 milligram dose, second is 2.4, and third is placebo. Dysesthesias, funny sensations. Almost 1 out of 4 people with the higher dose described these side effects. Look at the number for 2.4 milligram. That is only 6%. And so this is the key thing to watch out for and a reason to cut that dose back down to 2.4 milligrams for tolerability. Make sure your patients are aware of that. GI adverse events just lumped together, 7 out of 10 versus 6 out of 10. And then half or 40% of the patients on placebo had some sort of GI adverse event, which tells you something. So what about events that led you to have to discontinue or reduce the dose? About 18% of people on the 7.2 milligram dose had their dose reduced, and only 5% had to discontinue the medication. So moral of the story, many patients still tolerated the medicine. Things that I would be watchful for are just our general GI side effects and dysesthesia, and just really making sure that we're titrating up. Patients get impatient, I think. Wow, do I really have to take that lower dose for 4 weeks? I feel fine. But because we know that the GI side effects particularly come with dose initiation and escalation, we want to be really patient when we're escalating our doses. Okay, moving on to Wegovy pill. You all are comfortable in treating type 2 diabetes, so you'll become comfortable with semaglutide that is brand name Ribelsis. So now I'm going to tell you about the Wegovy pill, semaglutide 25 milligrams, and I'm going to ask you to forget some of the things you know about Ribelsis because they're formulated differently and the doses are different. So this is the Oasis 1 study. This was published in 2025. The patients who were in the clinical trial for Wegovy pill did not have type 2 diabetes. They had those usual criteria of BMI of 30 or more or 27 or more with one of these or another comorbidity, and they had already tried a dietary weight loss attempt. If they had a recent fluctuation in weight, they were not included. If they had had a recent trial of another weight management medication, they were not included, or history of pancreatitis. So the kind of bottom line results here on the right, blue is that oral semaglutide and gray is the placebo. And we can see that 80% lost 5% of their body weight, 63% 10%, 50% of people lost 15%, and about a third 20%. So really these are like fairly comparable in my mind to the higher dose subcutaneous information that I just gave you from the step up trial. What I think is always fascinating is that diet works. Diet works for some people, lifestyle changes work. So you can see with that yellow star, about a third of the people in the placebo group lost 5% or more of their body weight. So looking at changes over time, and I think it's so important to make sure our patients understand to be patient in the first few months. So we can see at that 1 month mark, we're starting to see a signal. We're starting to see about 2% average weight loss. And then by the 12-week mark is when we're going to see about 5 or 6% body weight loss. When we look over time, how long does it take for patients to plateau? Well, gosh darn it, it takes almost an entire year. It takes almost an entire year for patients to reach that new set point weight. And in this clinical trial, everyone was attempting to titrate up to the 25 milligram dose or maximally tolerated. The other thing I think is important here is looking at the number of participants in this trial. So they only had 205 individuals initiate the trial on oral semaglutide or Wegovy pill. It's a large enough clinical trial for the endpoints, but kind of a small group of patients. So what you're going to see is much wider variability in those outcomes. So giving you information about adverse events, just again to highlight that the numbers are not that different than other GLP-based therapies, and this medication is pretty well tolerated. So leading to discontinuation, about 7% of individuals prescribed oral semaglutide, and about 4 to 5 out of 10 people experienced nausea, vomiting, etc. Those GI side effects are just really common. We know that they're higher on initiation and dose escalation, and for most people improve over time. So here's the slide to pay attention to in terms of comparing oral semaglutide for obesity to Ribelsis. In order to get the higher dose of semaglutide to absorb in the GI tract, semaglutide is still a peptide. It is a large protein and it degrades rapidly in the stomach. So it is co-formulated with SNAC, and I will try to pronounce this, salgaprosate sodium. It is co-formulated with SNAC, which is our shorthand, and SNAC is a formulation that helps localize the increase in pH at the tablet surface and enhances transcellular absorption into the mucous membrane in the GI tract. So that is the special co-formulation that makes this absorb. What is important to know, it does delay gastric emptying and there are drug interactions. So specifically be really careful with levothyroxine. It can increase levothyroxine exposure by 33%. So the recommendation is if your patient takes both semaglutide pill and levothyroxine, dose the levothyroxine at night. All right, the next information is about dosing. The lowest dose of this new formulation of semaglutide is going to be available at 1.5 milligrams, and it will dose titrate every 30 days. So you will provide a prescription for 1.5 milligrams for 30 days, and then 4 milligrams, and then 9 milligrams, and then up to 25 milligrams. Now, if your patient experiences bothersome adverse events, you will slow down that titration. Interestingly enough, just because of the efficacy, is the medication going to be effective for weight management? The recommendation in the prescribing information is that if someone does not tolerate the 25 milligram dose, you should consider switching to subcutaneous. And the switch is from 25 milligrams oral to 1.7 milligrams subcutaneous. These instructions, again, we go over in detail, and when patients are not seeing weight loss, it's often because they are not following the instructions. It's finicky. You have to take it first thing in the morning, no more than 4 ounces of water, no other liquids, swallow the tablets whole, and you must wait 30 minutes before other food, drink, or oral medications. And then if you miss a dose, you'll skip it and take it the next day. So this switching information is in the prescribing information for you. If you have a patient that's on 2.4 milligrams of subcutaneous semaglutide Wegovy, you can switch them directly to 25 milligrams. That is how they switched patients in the trial, because the bioavailability is similar between 2.4 subcutaneous and 25 oral. If your patient is on 25 milligrams of oral, they can be transitioned straight to 2.4 milligrams sub-Q. And again, after a subcutaneous injection, you'll wait a week for the pill. After a pill, you'll start the subcutaneous injection the next day. And then for patients who have intolerance, you're going to start Wegovy 1.7 milligrams weekly. So if you ask me, how do I transition patients from tirzepatide to Wegovy pill, I'll say you have to use your best clinical judgment, because there's no information from the manufacturer to guide you. So that is your update for semaglutide Wegovy pill. That medication has been available now for maybe a little less than a month, and so you may have already started prescribing it or having patients request or ask about it. Okay, last medication. Thank you for sticking around to the end. This is the last piece of information I'll share with you. And this is orforglipron, brand name Foundayo. I had finished this presentation, and then last week I had a patient message me. Orforglipron has been approved. Can you tell me about it? And so this medication was approved by the FDA on April 1st, 2026, and should be available for prescribing this week or next week. I'm going to share information from the Attain-1 trial, again, a trial in 2025. And this trial of orforglipron had really similar inclusion criteria, again, to many of the trials that we presented to you in the past for weight management medications. And then what's interesting is that they excluded people with impaired gastric emptying, excluded people with severe renal or hepatic disease or recent cardiac events. And here you can see that change in body weight from baseline to week 72, 7.5% with an orforglipron dose of 6 milligrams, 8.4% with 12 milligrams, and 11.2% with 36 milligrams, with a placebo effect of 2.1%. So if you subtract that, then that will give you about a 9% weight loss, placebo subtracted for orforglipron. This information again shows you the change in body weight over time, and I think if you take nothing else away from looking at these graphs, it's that it takes a long time to achieve weight maintenance. It will take patients approximately 11 to 12 months to achieve that new set point weight on medication, and you can see a reasonable difference between the lower doses and higher doses of medication in overall weight loss. Again, trying to just ground us in every patient responding differently, and I'm going to have you look at that darkest blue, which is the 36 milligram or highest dose in the clinical trial of orforglipron, and 7 out of 10 people lost 5% of their body weight. That means that 3 out of 10 people did not respond to this medication in the clinical trial. About half achieved 10% body weight loss. About a third achieved 15% body weight loss, and about 2 out of 10 achieved 20% body weight loss. So medication, as I tell my patients, some medications are effective for some patients, but not every medication is effective for every patient, but very, very reasonable, again, just to watch these patients out to see how they respond to this medication. If you've started thinking about prescribing this medication under the brand name Foundayo, you will note that what is available is 7.2 milligrams. And you might ask yourself, Dr. Ashman, you just told me in the clinical trial it was 36 milligrams. How come they only are marketing 7.2 milligrams, 17.2 milligrams? This information is all from Lilly USA, so a direct request from the drug company to answer this question for you. Capsules and tablets have different molecular weights and absorption. So 36 milligrams in the clinical trial is going to equal 17.2 milligrams of a pill. And so we're going to start with a 0.8 milligram and dose titrate patients up, and I'll tell you a little bit about that now. We're going to start patients at 0.8 milligrams, and then every 30 days, we are going to increase the dose, 2.5 milligrams, and then 5.5 milligrams, and you can stay there. So if someone is having a good response or has GI intolerability, 5.5 milligrams is the lowest maintenance dose. After another 30 days, you can increase to 9 milligrams and so on and so forth to that top dose of 17.2 milligrams. And so, similar with a lot of our GLP-based therapies, it's a really slow dose titration. It's going to take you 6 months to get up to that maximum dose. These tablets should not be broken, crushed, or chewed. The reason I am excited about this medication is because it is not finicky. Because orforglipron is not a large peptide, it is not easy to break down in the GI tract. It can be taken with or without food any time of day. If you miss a dose, take it as soon as possible. And then only if you miss 7 doses in a row would you restart at a lower dose. So then again, after 5.5 milligrams, you can increase the dose to 914.5 or 17.2 milligrams based on response and tolerability. So I'll just share some basic information about the difference between a peptide and a non-peptide agonist. Orforglipron is just a plain old GLP-1 receptor agonist. There is no additional mechanism of action. But the feasibility of developing these non-peptide agonists has historically been really challenging because of concerns that these tiny molecules would be unable to mimic the mechanism of the GLP receptor in these large, like high molecular surfaces, if you're thinking about a lock and a key with binding to that receptor site. And so it took a lot of work to find a small, tiny molecule that would have that binding effect. And there's a lot more detail that I could go into if you were interested in basic pharmacology. What is important is that the maximum concentration happens at about 4 to 8 hours. Half-life is 1 to 2 days. And then we're going to talk about caution with hepatic impairment, and we're going to talk about drug interactions. Historically, what we can appreciate about subcutaneous semaglutide and tirzepatide is that there are very few drug interactions, especially with liver enzymes, because they are subcutaneous. So now I just want you to reorient as you're starting to think about prescribing either oral semaglutide or oral orforglipron. We need to put back on that hat thinking about drug interactions. And so I'll say this twice, but we need to limit simvastatin to 20 milligrams when we're using this medication. The other drug interactions that are important are CYP3A4 inhibitors and anything that is a CYP3A4 and OATP1B1 inhibitor. That is ritonavir and ketoconazole. So I'm leaving this chart here for you just to remember that patients prescribed ritonavir and some, again, other medications that you're unlikely to prescribe should not have orforglipron prescribed. And then medications that are in that strong CYP3A4 inhibition category alone, you want to limit your orforglipron to 9 milligrams. And so again, just to say some of these drugs out loud, it would mostly be longer-term ketoconazole or voriconazole prescriptions. Ritonavir and other HIV meds are the most common ones on that list that you might use. So what about switching to and from orforglipron? Well, there is some information here, and this is from a trial called Attain Maintain. These patients were treated with tirzepatide subcutaneous and then enrolled in the orforglipron trial, or they received semaglutide subcutaneous and then went to orforglipron. So Patients were on their maximally tolerated dose of tirzepatide that was either 10 or 15 milligrams, and they were switched to 12 of orforglipron, or they were on 1.7 or 2.4 of semaglutide and switched to 12 of orforglipron and then titrated up. So that's the information you're going to remember when you're switching people to this new drug, Foundayo or orforglipron. I think this is interesting information, again, obtained at my request from Lily to share with you, and I'll just take you through this because it's a little bit dense. For those patients on semaglutide, again, they had either 1.7 or 2.4 milligrams subcutaneous. Their starting weight when they started that semaglutide arm of the trial was 113.5 kilograms. So they used semaglutide 2.4 milligrams, and then when they were switched over to orforglipron, their weight on average was 95 kilograms. Then they were titrated up to the maximally effective dose of orforglipron, and their weight stayed stable at 95.9 kilograms. That's a pound of weight difference. So what that says to me is that on average, patients who responded to semaglutide 2.4 or the highest dose of Wegovy injection had weight maintenance with orforglipron. I think there are environmental reasons that you wouldn't want patients to have injection in a glass vial every month. Orforglipron as a tablet is going to be less expensive to manufacture and have potentially less of a environmental footprint. But whatever your preference, your patient's preference, or insurance preferences are, that's a very reasonable change. Now let's look at tirzepatide subcutaneous to orforglipron. Again, those patients started taking tirzepatide at an average weight of 115.8 kilograms, lost weight down to 90.9 kilograms, and then they had weight gain. So this is really where you're seeing the difference. Some patients who have tirzepatide who are switched to orforglipron for weight maintenance may have some weight gain. So again, just information to share with you. And what's important is that there was no 7.2 milligram dose of Wegovy injection for this trial. So I can't tell you anything about that. Just want to share adverse effects, and again, appreciate that the rate of nausea in that highest dose, the 7.2 milligrams of Foundayo over on the far right was about 35%. Numbers are pretty similar across different GLP-based therapies. I just tell my patients you're likely to have some GI effects when you start the medication. Contraindications. So as with any GLP-based therapy, medullary thyroid cancer, multiple endocrine neoplasia 2 syndrome, or allergy to the drug. Warnings: pancreatitis, someone who's very likely to have a severe GI reaction. There's specific warning here because of the gastric emptying issues to avoid with severe gastroparesis. If someone gets very dehydrated, they may be more likely to have acute kidney injury. If they're on other glucose-lowering agents that can cause hypoglycemia, insulin, sulfonylureas, they may have hypoglycemia or hypersensitivity reactions. Diabetic retinopathy, again, a continuing area of concern, but these would be patients who would not have diabetes. I will tell you that there are ongoing trials for orforglipron for diabetes, and that information will be shared at a different time. Anytime you lose weight fast, you might be at risk for acute gallbladder disease, so something to keep in mind. And then just specific for this medication, because they looked very carefully at gastric emptying, they added a risk of pulmonary aspiration. Reproductive concerns, different than other GLP-1 receptor agonists, that Foundayo does have some known gastric emptying effect that could affect OCP. So you're going to see the same warning here that you see on tirzepatide products, and that is to switch to a non-oral method or add a barrier method for 30 days after initiation and 30 days after every dose escalation. Now, I just told you it's going to take 6 months to titrate up to 17.2 milligrams. And so that's 6 months of considering with your patients, what do you want to do for birth control in this time period? Really, really important to talk about that before initiating this medication. Orforglipron or Foundayo availability and pricing. Again, we are price neutral here at MCT2D, but just giving this information to you. It's all available on the website of the drug manufacturer. And I think what's important about many of these medications that patients are being asked to pay cash for is that they need to be refilled every 45 days. So if a patient is spacing their medication out, in addition to not being as effective, then the insurance company is, sorry, the drug manufacturer is penalizing the patient by charging them more medication. So just again, appreciating that this is the information that I can share with you right now. So resources that I want you to be aware of, just again, bookmark that Michigan Medicaid website. Make sure that you have some documentation available to support your clinical rationale and information required for medications to be approved for your patients for Michigan Medicaid. Remembering that patients with a BMI under 40 are no longer eligible for any GLP-based therapies for weight management in Medicaid. But Medicaid still covers those medications for type 2 diabetes and covers those medications for sleep apnea, for cardiovascular risk reduction in appropriate patients, and for patients with MASH. And so we went over all of the information about that today, and then information available about the prior authorization criteria is here. So in summary, hopefully you stuck with me through this very long presentation, but found the information that was helpful for you. You know that Michigan Medicaid coverage has changed. You know how you are going to utilize older weight management medications to help take great care of your patients. And you have some information to take away about safely prescribing newer GLP-based drugs as those disseminate into your practice this year. Here are my references, and this presentation will be recorded and available for you for your review, and I hope you have a wonderful April 2026.